can. My name is James Kent. I have a private practice in Tyler, Texas, and I'll say this starting out: you don't have a clue how happy I am to be here. I'll tell you a little story. When I was in Nashville, Tennessee, at the AAPPM meeting, there was a flyer for the Academy of Ambulatory Foot and Ankle Surgery, and I looked at it, and it had some things that I really liked. And you know, I trained with Dr. Laporta, and I love Dr. Laporta. And I do probably 60% minimally invasive surgery. I'll probably do about 40% traditional. But you don't have a clue how proud I am to be here. I'm going to talk to you about minimally invasive Haglunds deformities. And I think Haglunds deformities are an okay procedure to do in the office. But I think the main thing is you have to pick your poison. I think when you're looking at a Haglunds deformity, you really have to look at the patient. You have to look at the size of the patient. You have to determine, is this a person that really needs a Haglunds deformity? I've seen a lot of problems in hospitals when doctors try to do Haglunds deformities and try to do Achilles tendon detachments and try to take the bone off. And I've seen some absolute disasters. There was a case when we were in a hospital in Texas, and the woman, she was every bit of 300 pounds, 350 pounds, and what happened, one of the attendings tried to do a Haglunds deformity surgery and did an Achilles tendon detachment, and within 2 days it completely shredded apart. And at that time I had like a week left when I was a student, and I left, and I don't know what happened to the woman, but I can tell you one thing, it wasn't pretty. So this is really my favorite slide, and you can't really see the bottom. Well, I think you can, but besides being proud to be here, here's what I really like about the Academy of Ambulatory Foot and Ankle Surgery. If you look on their website, they have basically 3 mission statements, okay? And basically, the first one I really, really like. The patient can basically walk into a doctor's office and walk out, okay? I absolutely love that. The second is absolutely my favorite. What you're trying to do, you're trying to restore a person's foot health and ankle health at the lowest possible cost to the patient and the doctor. And I think, you know, in the 70s, 80s, and 90s, that wasn't such a big deal. I think it's getting to the point where it's getting a huge deal. I think it's getting even more. And quite frankly, we're going to have to start looking at some alternative ways to do things. And I think if a person's not willing to do that, I think they could potentially be in big trouble later on. And so if you look at education, I'm big into education. I love to teach. I've got a lot of hits on my YouTube channel. I put lots of stuff on my YouTube channel. And we get a lot of phone calls from people from New York or Florida or wherever, and they're wanting to look me up. And it's not because I'm such a great surgeon. I'm no better than anybody here. There's a lot of people that are better surgeons than I am here. But I think if we learn how to market the academy, and I think we can really help some people, and I think we can lower the cost for healthcare in America. Okay, so this is my opinion on ambulatory foot and ankle surgery. You know, people really don't ask me, am I board certified or my credentials? They want to know 3 things. And if I could probably tell you the most important part to this lecture, patients ask me, number 1, can you fix my foot? Number 2, how much does it cost to fix my foot? And number 3, how convenient is it for me to have this procedure done? Okay, but nobody really asks me, are you board certified? What's your operating room look like? What hospital do you go to? It's, can you fix my foot? How much does it cost? And how convenient is it for me to have this procedure? I really believe that, and that's what people ask me. So getting really into the meat and potatoes of this lecture, if you're looking at these 2 slides, obviously you've got Haglunds deformities on both. On the left, this is extreme. On the right, it's a Haglunds deformity, but it's a very mild Haglunds deformity. Okay, this is my opinion of the left slide. Okay, obviously you have some form of calcification embedded inside that Achilles tendon. In my opinion, this patient is definitely not a candidate for an in-office Haglunds deformity. I think you'd be crazy to do that. In all honesty, if a person were to try to do a surgery on that patient, I think it'd be a disaster like the hospital that I saw in Texas, okay? But if you look at the one on the right, this is a very mild Haglunds deformity. If the patient is the right patient, if they're small, petite, this could be done in the office, okay? So if you're looking at the various sizes, it's first described by Haglund in 1928. And you know, people put tons, literally tons of weight on their feet. And obviously, you know, if you're looking at the forces, you're looking at about a ton of weight. You know, that's putting a lot of pressure on that calcification down there. So if you're looking at this next slide, you're looking at the Fowler filler angle, you know, greater than 75 degrees, you're looking at a possible Haglunds deformity. But really for me, I look at one thing, how does the patient feel? Because I've seen people with Haglunds deformities that really don't have any pain at all. They don't. You'll come in and you'll see a patient. I had one the other day, and we took an x-ray, and I was just assuming that she was going to have pain in this area. No, it was just simple plantar fasciitis. So it's absolutely crazy to go in there and do a Haglunds deformity surgery when you're really not having any pain. So if you're looking at symptoms, it's a bony bump on the back of your heel, okay? Everybody's seen it before, thousands of times, hundreds of times. Severe pain around where the Achilles tendon attachment is. You have swelling around the bursa. It's fluid-filled sac. You always have this redness around this area. It's constant pain. It's obvious. They'll usually point to it, okay? So if you're looking at this slide, okay, this is also one of my favorite slides to the lecture in the fact that I'm probably the most anti-surgery surgeon you'll ever meet. I really try to push surgeries away. I desperately try to get patients away from doing any type of surgery. I can't stand doing a surgery when I can just put them in something very simple, or give them some diclofenac gel or a Medrol dose pack or an open-toed shoe. But if you look at some of these treatments, from cam boots, some people give injections, cortisone injections, heel lifts, open back shoes, physical therapy, orthotics, Medrol dose packs, laser therapies. I have all this stuff at my office, and this is the things that I try to do. And I'm sure there's other treatments, but this is what I do to try to keep them from having a surgery, okay? So if you're looking at a traditional open versus minimally invasive surgery, obviously you're going to have pros and you're going to have cons to everything you do. Why I like minimally invasive surgery, it's usually, not always, but you usually have less trauma, you usually have less pain, you usually have less downtime, and my favorite, it's less money, usually for the patient, okay? So what is the cons of MIS? Well, obviously, one of the cons is you don't directly see the bone with your eye. But if you have the right instruments, you have a C-arm, you're well trained, you're confident on what you're going to do, it shouldn't be that bad, okay? So if you're looking at this is actually my operating room in my office. I decided to spend the money and build this room, and I tried to make it as close to a high-level ASC, and for me, I've just decided it's better. It's much better. I don't really put anybody under anesthesia. My patients really enjoy it. They walk in, they walk out. If you look at this room, you've got your ankle scope, you got your lights, you got a TV set, a barrier, a person can watch TV while the surgery is being performed. We've got a little tourniquet there. We've got our nitrous oxide gas. We've got our little C-arm, little Stryker TPS unit with our OSADA drills as well. And then this is the back side. We have our little clean room in the back, and we have sterile drapes, oxygen, C-arm, all that kind of jazz in there. But that's what I've just decided to do, and to be honest with you, I won't go back. I just will not go back. So if you're looking at positioning of the patient, I like to do it prone. First, I like to numb it up when they're sitting on their back in supine. And then once I get them numb with an ankle block, I usually put them prone where they can sit on their side. And this is one of my assistants. And of course, I put on a sterile drape. You got that going, and they can put on their headphones, or they can, play with their iPad or their phone while they're having their surgery done. Okay. So if you're looking at anesthesia, this is really all I use. It's getting to the point where this is truly all I use. I use lidocaine. Very, very rarely do I use epinephrine. As a matter of fact, I hardly ever use epinephrine. You just give them a little bit of cold spray, maybe give them a little tablet of morphine before, or a little Vicodin tablet. Sometimes doctors want to use a little Valium or a Xanax or a little Halcyon tablet like the dentists use. And in Texas, actually, we can do nitrous gas. So that's really nice. Give them a little nitrous gas, about 50% nitrous for about 4 minutes, trying to get them a little bit happy, give them the injection, take it off, and then they don't even need nitrous anymore. Once you're numb, there's no point in giving them nitrous anymore. And so I tell people, just put on some headphones, watch some TV, bring your iPad, bring a book, and then put up a vision block. I've got a good vision block, and there you go. So if you're looking at a local block, this is my local blocks. You just give it just proximal to where you're going to make the small incision. And then you go right in here